most departments don't have a digital health center. It's a more global thing, part of the enterprise. But ours is, I think, a little bit different circumstances why we have that. We started with doing some research for telemedicine with COPD as an outgrowth of a grant over a decade ago. It was part of a grant that we got from the state of Pennsylvania. And over the last 10 years, that's morphed into changing the interactions with patients, refining the algorithms of what we do for intervention with the prompting from the data from the patients, and then also trying to make it more facile and mobile with the use of new devices such as smartphones that patients have or smartwatches that some of them have.
That's an Apple Watch you've got there?
That's an Apple Watch. Trying to like embed information that would be important to patient groups that we treat. So our department, which is thoracic medicine and surgery, as you can imagine, we treat patients from a broad geographic area, but patients with chronic and severe diseases like COPD or asthma, or people that are listed for lung transplant or following lung transplant. It makes it important for us to monitor their condition on a daily basis. So the reason why we have a digital health that sits in our department is those two reasons. We've been working on it for 10 years. We thought it's a good technology. It bridges to a large patient group that has need of, on a daily basis, of staying in communication with them. And a number of the parameters in nerve diseases lend themselves to telemedicine technology that have important parameters that patient can self-report or give us information that we can act on a a regular basis.
So this grew, like you said, grew out of telemedicine, and I guess has evolved as the technology has gotten better and has moved into the personal realm and not just the clinical realm, instead of just the clinical realm.
Yeah, instead of a research realm, it's moved into a disease management programs that we have for certain diseases.
And meanwhile, you now have new financial imperatives to prevent hospital admissions.
Yeah, that's one of the things that's going to be very useful, is that we have patients that have been hospitalized that we want to keep track of closer, or people whose history suggests that they're sicker that we want to keep closer to prevent them from being hospitalized or coming to the emergency room. But overall, it's been beneficial in showing the daily burden of what patients have, so you can affect treatments that change the trajectory of the disease, not just reacting to a symptom that might be worse that day when a patient's daily burden of disease is high and higher than what you would expect. So there's a lot of different advantages it has, I believe.
Okay, so you're trying to be proactive rather than reactive, which seems to be a popular thing these days in medicine.
Yeah, and I think one of the things, there was some skepticism when we first started that patients wouldn't report on a daily basis or would be leery of technology, or a lot of our patients, the COPD, interstitial lung disease group, is older. They're like, the mean age is 68. But those
you said 78 or 68?
68. Okay. But we have people up to 85 that use it. But the patients have evolved. That most patients, even of an older age, I'd say 80% of them now have a smartphone or their spouse, or they have a computer, and they interact on a daily basis. And they seem to like, wouldn't say enjoy it, but in some respects, they're comforted by it. They believe that that's a way to communicate.
Yeah. Well, they see it. You probably frame it to them as a lifestyle choice that's, easier to make than some changes that might have had to have been made in the past. You want to keep them out of the hospital, keep them out of nursing homes, let them, essentially age in place, as the saying goes.
Well, I think it's an adjunctive tool, and what it does is it also self-teaches patients. It allows them to know what their characteristics are on a better day than a worse day. They appreciate what the changes are in terms of objective measures of like airflow and whatever. And they become very good at being able to like record their data. And it's not, if you can treat patients this way and don't collect too much information, it takes us about a minute.
Where do you expect to go with this center? I mean, you're just getting it off the ground.
Yeah, I think some of the things that we have in improving patients' outcome. We're looking at trying to refine the algorithms and the data so we can personalize the treatment based on the patient's prior successful pattern of treatment in the past. Trying to do some different things with taking these parameters and see if we can dichotomize or phenotype the patient groups into those that are more likely to be admitted to the hospital or need more treatment, so we can do a better job of like allocating resources and improving their condition and maybe augmenting their therapy proactively. We're looking at trying to the impact of comorbid conditions in these patient groups and see if we can impact their prime disease by doing a better job of treating the comorbid conditions on a daily basis. So I think it's a variety of different things that we'd like to accomplish with our patient groups.